got to morph this also into what can we do about it. It does you no good to make a diagnosis unless you've got something to offer, right? Which brings us to GOLD and the COPD Foundation treatment algorithms. Why don't, Fernando, you want to start running through those?
So you know, I mean, I think that all of my colleagues have already made some of these comments, it's clear that there has been nihilism in this disease. There's no question about it. And there's been a pejorative component in terms of the exposure history. Peter, all of that is correct. But having dealt personally in my family with severe COPD, it is also important to realize something that all three of my colleagues have said, and that is in contrast to even the previous definitions for COPD, which if you read them were like progressive disease, you know, you would read them and you go, oh my God, this is horrible. The definitions have been changed and have been changed to incorporate two important concepts, and that is A, it's preventable, and B, it is treatable across the spectrum of disease. And so when you look at what's occurred in terms of the multi-specialty guidelines, whether it's the COPD Foundation work that Byron has led, or whether it's the GOLD group, which is an international group, that all of those have worked under the same paradigm, preventable and treatable. The complexity of treatment is there because, as Frank points out, it's a heterogeneous disorder. But there's a very rigorous approach that's been taken by all of those recommendations to point out that at every stage of COPD, no matter where you diagnose the patient, you have therapeutic interventions that clearly can make the patient feel better and can have implications in terms of what occurs to their disease over time. Those are crucial concepts.
So that you can address the progression of the disease, you can address exacerbations then?
Yes. So one of the factors that bridges that last question to this is that it's not just the symptoms that they say, and that you have to probe. You have to probe with these questionnaires, because what these folks, some of them are still smoking. They don't want to have that lecture. They know what's coming next. And often what happens is they suppress, even in their own heads, that they have symptoms. They start withdrawing from activity. They do less and less and less. So if you just say, do you have symptoms? They may say, no. And you say, what are you doing? Well, I sit on the couch all day. And
it's like claudication, right? I don't have claudication. How much do you want? I stopped doing that.
Same idea.
Same thing, exactly. And if you don't find out what they've withdrawn from life, what happened to their quality of life, you're not going to elucidate that they have an impairment. It's not just shortness of breath and cough.
And Peter, when we actually included, and the development of capture is just one of several instruments that have been developed. Frank, Byron, I don't know if you had noticed the same thing, that when you actually developed that type of a simple approach, 5 questions, something simple for primary care, and you included primary care clinicians and patients, this is exactly what patients said. Exactly this, is that you're not asking this correctly. You need to be asking the way Frank just said.
You know, what strikes me is a paradigm from the aviation industry. Somebody at Boeing finally woke up and said, why don't we ask pilots what they'd like in a cockpit? And they got a vastly different answer. What a concept than what the engineers were providing.
Yes.
So because we were talking about therapy, and that everyone's been alluding to this, that we finally have something that works, we have a whole class of things that do work. We've got all kinds of drugs, the short-acting bronchodilators, long-acting bronchodilators, muscarinic receptor antagonists, inhaled corticosteroids. Why don't we start by just, in a very organized way, running down this list? The short-acting bronchodilators, give me an overview of this class.
Well, the thing that has changed, I think, in our thinking, coming back to that definition, one word that is partially reversible. So in the past, we used to think it was progressive, inexorable, and irreversible. So finally, people have actually looked at the patients, made some measurements. So there is a component. It's not asthma, but it's a little bit like asthma. So the short-acting agents can be used in COPD, first as rescue, and that's what the GOLD guidelines say. And there's beta agonists like albuterol and anti-muscarinic short-acting ones like ipratropium. Those agents also, as opposed to asthma, can be used regularly if you wanted to, but there's no reason because we have better long-acting agents.
And for the sake of this discussion, we'll call the short-acting bronchodilators
rescue.
SABA.
SABA, yeah.
Short-acting bronchodilators.
Okay.
As opposed to long-acting bronchodilators,
correct.
LABA.
Right.
Help me out on that.
So the LABAs will last either 12 or 24 hours. That's the FDA definition of a long-acting agent. And We have many of them. The muscarinics, we have, the first one was tiotropium, and now we have umeclidinium, aclidinium, glycopyrronium. So there's a whole variety of them. They're all fairly similar in efficacy.
But I don't want to conflate these. In other words, there's long-acting bronchodilators, which are LABAs.
Yeah, these
and
are the muscarinics.
There is a distinction there between the long-acting muscarinics,
right, and these are
and LAMAs.
Right, the muscarinics block the cholinergic system. The long-acting beta agonists are stimulatory, and the beauty of these two systems is that they work together. There's crosstalk, there's synergy, one presynaptically enhances the other. So the beauty of the long-acting beta agonist and the long-acting muscarinics is you can put them together in a single inhaler and have a very large effect on lung function and hopefully symptoms.
So there's two receptors. One's the beta and one's the muscarinics.
Correct.
Right?
So
Okay.
let me ask Jim a question about this, because this is the way I try to explain it to my father-in-law. And so, as you said, Peter, there are two different receptors that we're targeting, beta receptor and the muscarinic receptors. Then there are short-acting preparations that can target either of those or combinations of those. And those are drugs that have relatively rapid effects, but relatively short duration effects, right? So short-acting agents that include beta agonists, antimuscarinics, that can be combined. Mm-hmm. And if a person has persistent symptoms, then you can look at long-acting versions of targeting those two receptors. That are the long-acting beta agonists, those are the ones we call the LABAs, and then there are long-acting antimuscarinics, which we call the LAMAs. And those can also be combined. And the one advantage, Peter, I mean, it is an advantage for some of those that have been doing this a long time, where we used to have only one or two agents in this class, where you now have agents that you can choose that can be dosed twice a day, once a day. A whole series of devices. I mean, Donohue's made his entire life developing these agents. And so does that make, you think, a
Absolutely,
practical approach
that's
to looking
spot
at
on.
it?
The one lasts 4 to 6 hours, the short one, and then it's gone, and whereas the long one lasts 24 hours, and there's still effect when you wake up in the morning. You know, when I was a young doctor, and you could relate to this because of working in the rest of you in pulmonary and critical care, we used to do surgery on chest patients in the afternoon. I remember I did a couple rotations at Columbia and when I was in medical school and a house officer, and the surgery was done in the afternoon because patients did so poorly in the morning. But with this trough effect, which is about 100 cc's, 140 cc's, somewhere in that range, you wake up, you don't feel great, don't get me wrong, I'm not gonna underestimate it, but you feel much better than if you just took short agents that wore off in the middle of the night.
I got you. And you know, if you've been listening closely out there, I think you'll notice that there's a class of drugs nobody's mentioned, which are the inhaled corticosteroids. Have they fallen off a cliff? Are they still out there?
Well, we're going to be talking about this because they were in the process of falling off the cliff, but I think they may be resurrected with the new onset of what's called triple therapy. But for years, because of the fear of missing asthma, and we knew that one of the drugs for asthma, the long-acting beta agonist, had some increased side effect profile. So you never gave them by themselves. So you always gave the combination of an inhaled steroid and a LABA. And in COPD, it's a steroid-resistant disease for a variety of reasons. But again, with marketing, and because one shoe fits all, that kind of marketing approach, they led the marketplace, even more than monotherapy with a LAMA. Now that's too much. A brilliant discussion by Sammy Suissa from Canada shows that with inhaled steroids, there's a pneumonia signal with the more important ones. And if you just use the bronchodilators without the steroids, you probably will reduce hospitalizations due to exacerbations, but if you use the steroid, you might have some hospitalizations due to pneumonia. So that's what the debate. So there's been, and I think we're going to talk about it as we go along today, a lot of studies trying to decrease the use of corticosteroids in COPD by using the LABA-LAMA, which I thought Fernando brilliantly put it together in a nice package there because they work together. So, but there are people you must still use them in, and that would be people with the so-called asthma COPD overlap, people with frequent exacerbations, maybe, we're going to talk about it later, eosinophils greater than 300, and maybe people with very severe disease.